Hello everyone, good evening. Today we will discuss Hydrops fetalis. Mainly we will discuss non-immune Hydrops fetalis. So start with a definition. It is defined as presence of extracellular fluid in at least 2 body compartments. Okay, in at least 2 body compartments. So this can be, the fluid accumulation can be the skin thickness of more than 5 millimeter, or it can be pericardial effusion. Third, it can be pleural effusion. Fourth, ascites. Okay, in this picture I have shown this is ascites in the child. Okay, this red color, this is ascites in the child, and this is the skin thickness which is more than 5 mm thickness. In this picture I have shown pericardial effusion. This is pericardial effusion. These images are taken from Guwahati. The additional findings can include in this child while they are doing a USG. It can include polyhydramnios, which is defined as amniotic fluid index of more than 24 centimeter. It can the other additional finding is placentalomegaly. So placentalomegaly includes when the placenta is more than 4 centimeter thickness in second trimester, or more than 6 centimeter thickness in third trimester. Okay, these are the additional findings. This is the definition of the Hydrops fetalis. The incidence of non-immune Hydrops fetalis is 1 in 1700 to 3700 pregnancies. Next we will see the etiology of Hydrops fetalis. Etiology, it can be divided into immune and non-immune. In immune, you all know it is because of Rh incompatibility. In non-immune, the most common cause includes cardiovascular disease. So the most common cause is cardiovascular cause. So among the cardiovascular, what can cause the non-immune Hydrops fetalis are hypoplastic left heart syndrome, Epstein anomaly, endocardial cushion defect, or it can be arrhythmia. We have read about arrhythmia cause leading to Hydrops fetalis in fetal therapy. We have seen the treatment for that. Okay. Second most common is idiopathic. Okay. Third we have chromosomal category. Among chromosomal category, it includes trisomy 18, 21 or 45 exo, it is Turner. Fourth, hematological category. So this hematological category includes alpha thalassemia and feto-maternal hemorrhage. Fifth, it is infection. Among infection we have three main things, that is parvovirus, CMV and adenovirus. This adenovirus can lead to or it can cause fetal myocarditis. So that leads to this Hydrops fetalis. Okay. Sixth, we have thoracic causes category. In thoracic category, it includes any mass in the pleural space. It can be CCAM or congenital diaphragmatic hernia or hydrothorax, or it can be chylothorax. In seventh category, we have GI causes. GI causes includes meconium peritonitis, and GI obstruction. Eighth, that is renal category. So you have to come like in an order: chest, GI causes, and the next you are going for renal. Okay. Renal, you have some any urethral obstruction. Ninth category we will see for IEM. In IEM we have lysosomal storage disorders. In lysosomal storage disorders, it can be mucopolysaccharidosis, type 7, or it can include Gaucher's disease, and GM1 gangliosidosis. Okay, these are the causes of non-immune fetal hydrops. That is, start with cardiovascular category or cardiovascular cause, because this cardiovascular is the most common cause for non-immune Hydrops fetalis. It constitutes around 20%. So among cardiovascular we have hypoplastic left heart, Epstein anomaly, endocardial cushion defect and arrhythmia. Second most is idiopathic. Then you come for chromosomal, or you can remember like cardiovascular, CVS, RS, GI and renal, then hematological. Then even in any neonatal problem you will write about IEM. So IEM we have lysosomal storage disorders. Okay. Next we'll look on to the pathophysiology. In pathophysiology we have four main mechanisms leading to this extracellular fluid accumulation. First, it can be due to elevated central venous pressure. It's elevated central venous pressure. Second, it can be due to decreased oncotic pressure. Third, it is decreased lymphatic flow. Fourth, this everything can lead to increased capillary leak. Okay. I will show this. This image is taken from Avery's for the pathophysiology. So here we have cardiovascular disorder. Cardiovascular disorders can lead to obstructed flow or diverted blood flow or abnormal venous return. So everything can lead to decreased cardiac output, which leads to cardiac failure and increased umbilical venous pressure, which causes congestive heart failure, which in turn leads to increased central venous pressure, leading to increased fluid accumulation. In renal disorder, it is because of the obstruction it can cause fluid accumulation leading to volume overload, in turn leads to congestive heart failure and increased central venous pressure and increased interstitial fluid accumulation. In twin to twin syndrome or twinning, we have the receptor. The receptor twin will have hyperviscosity, which again leads to congestive heart failure and increased central venous pressure. In hematological disorder, like in alpha thalassemias and fetal maternal hemorrhage, the fetus will have anemia, which leads to hypoxia, and in turn will have increased cardiac output or high output or high output, so that leads to congestive cardiac failure and causes increased central venous pressure. In inborn error of metabolism, it leads to liver failure, which causes low plasma oncotic pressure. This low plasma oncotic pressure will also lead to increased interstitial fluid accumulation. In gastrointestinal disorders, if it is having a protein losing enteropathy, it will also have low oncotic pressure, which in turn will lead to increased interstitial fluid accumulation. In lymphatic dysplasia, there will be a reduced lymph flow, which in turn will lead to increased fluid accumulation. In the respiratory causes, that is in cystic adenoid malformation or lobar sequestration, it will cause increased intrathoracic pressure, which can obstruct the venous flow and leads to increased central venous pressure, which in turn causes increased interstitial fluid accumulation. Okay, this is for the understanding of the pathophysiology, each of the etiology which I have mentioned before. Okay, so this is about pathophysiology of Hydrops fetalis. Next we will see about the how are you going to evaluate and management of non-immune Hydrops fetalis. Okay, in initial ultrasound, if they have found out a fetal hydrops in initial ultrasound, then you have to proceed with a comprehensive ultrasound. Comprehensive ultrasound is nothing but a 3D ultrasound or a specific thing which you are going to find out. So to the comprehensive ultrasound, next you have to do a middle cerebral artery Doppler. It is to find out the peak systolic velocity, which in turn will indicate whether the fetus have anemia or not. Third, you have to do a fetal echo. So you proceed with comprehensive ultrasound, MCA Doppler and fetal echo. So in this, if the fetus have a unilateral pleural effusion or cystic thoracic mass, as I told in the fetal therapy, you can go on with proceed with thoracic amniotic shunt. Okay. Next, if the child has a solid thoracic mass, then you have to proceed with the fetal surgery, that is open fetal surgery. If the fetus in fetal echo, if it has a fetal supraventricular tachycardia, that is arrhythmia, then you give medical management, that is medical therapy. You give, that is in this child it has a hydrops plus SVT. Hydrops plus SVT, the drug of choice is flecainide. Or if the child has atrial flutter, then you give sotalol. Okay. Next, if it is a twin to twin transfusion, then you consider laser therapy, that is photocoagulation of the particular vessel. Then you do a MCA Doppler. In MCA Doppler, if it is more than 1.5 multiples of median, that is peak systolic velocity is more than 1.5 times, it indicates fetal anemia. Then you have to look for the cause of anemia. You have to classify whether the fetus or whether the maternal a history of parvovirus. Then you have to do Klecker bed case stain for fetal-maternal hemorrhage and maternal antibody screening. But for everything, when you find it out as fetal anemia, you have to do a intrauterine transfusion. Okay, if suppose it is less than or equal to, that is MCA Doppler is less than or equal to 1.5 times of multiples of median, then you have to do a maternal RPR. This RPR is done for find out whether mother has syphilis. If it is positive, even maternal syphilis can cause hydrops fetalis. So if it is positive, it indicates mother has syphilis. Then you give the treatment as penicillin. Then you treat it with penicillin. If this is negative, I'll write it in the next page. If maternal is negative, then you proceed with history of, if there is history of any previous hydrops offspring or consanguineous marriage or any sibling death. If so, if it is present, if it is positive, then you do a amniotic enzyme assay. So amniotic enzyme assay is mainly done for Niemann-Pick disease, Niemann-Pick disease A and C. Next you do for Ullmann disease. Third you can do for Fabry's disease. Fourth, mucopolysaccharidosis. And fifth for multiple sulfatase deficiency. Okay, if the mother doesn't have any history of previous hydrops offspring or there is no consanguineous marriage, what you are going to do? If this is negative, next you can proceed with fish. Second, karyotyping. Third, you can do PCR for torch infections, enterovirus and adenovirus. This everything you are doing it in amniotic fluid, that is by using amniocentesis. Okay, then you can estimate the level of mucopolysaccharide and neuramic acid level. Okay, if the mother doesn't have any history of previous hydrops or there is no consanguineous marriage. So this is about how you are going to evaluate and management of non-immune hydrops fetalis. Okay, next we will discuss here the delivery room management, because previously you will be knowing, after seeing the ultrasound, you will be knowing that you are going to deliver this hydrops fetalis. You are expecting a hydrops fetalis baby. So first, in the resuscitation room or in the delivery room, if the location and severity of the extravascular fluid is known, or it is very severe, you can do a immediate drainage. So if the location and there is increased severity of extravascular fluid, then you can do a immediate drainage as a part of initial resuscitation. Okay. Then post delivery. In post delivery, you are managing according to the etiology. If suppose the child has a pleural effusion, chylothorax, hydrothorax, then you give a ICD. If it is ascites, then you drain it. They drain the extra fluid. Third, fluid management. The fluid management for this child includes, it is calculated according to dry weight. It is calculated according to the dry weight. Let us start with 40 to 60 ml per kg per day. Then you have to monitor the electrolytes, urine, and the fluid drainage, how much you are draining it in ICD and in ascites. Okay. Fourth, if the child is anemic or the child is anemic with heart failure, then you can give a euvolemic partial exchange transfusion. Okay. If the child is having anemia with heart failure. So in the anemia meaning, if the child has hematocrit of less than 30%. This partial exchange transfusion is done to improve the oxygen carrying capacity. So therefore it can reduce the risk of congestive cardiac failure. So this is about the Hydrops fetalis. Mainly about, we have discussed about non-immune Hydrops fetalis. Okay. If any doubt, kindly give